Today's session is going to be focusing on best practices for providing telehealth care to children with medical complexity. Our presenter is going to be Dr. Michelle CoIIN. Michelle CoIIN is a developmental behavioral pediatrician. She is a director of the Riley School Success Clinic and currently serves as an assistant professor of clinical pediatrics in Riley Child Development of Indiana University School of Medicine since 2016. She's passionate about identification and support of children and teens with learning differences, which she shares with her medical learners of all levels. She holds a medical degree from New York College of Osteopathic Medicine, completed a pediatric residency at Palmetto Health, University of South Carolina, and was the first developmental behavioral fellow at the University of Louisville. Michelle, I'm going to turn it over to you.
Thanks so much. Thank you all so much for having me. It's such a pleasure to work with the AAP team and to connect with pediatricians, especially right now during COVID, when things feel even more isolated than our day-to-day crazy running around. So thank you so much for having me. It's great to be here. Amy, am I in control? No, you've got the slides. All right, so I have no conflicts. I have no disclosures yet. As all of my mentors say, someday maybe I will be excited to have some disclosures. So today's objectives, we're just going to talk a little bit about when can telehealth actually be the right fit for a child and their family, when telehealth is even an option for your practice or for that family. We're going to discuss the equity around access and thinking about how to work around some of the barriers that can make that less achievable. And then we're going to talk about engaging families and how telehealth care can be useful for their child and when to make it the kind of shining star that it deserves to be at times. So first, we're just going to talk about considering telehealth use. And I don't know normally if there's a Q&A section at the very end. I know that that's there. I'm okay with also, I can see the chat box. So if people want to throw chat box questions in as we're going, and either someone can read them to me or I can look at them as well. I'm happy to do that. So telehealth in general has a lot of benefits. And I think sometimes we get worried about the negatives that we forget those benefits, but it really helps for folks who are physically distant. It really helps for folks who have a hard time with travel, even if they're not physically very distant. So if they're on the other side of your city or they're on the other side of town, depending on your lingo where you are, just getting to where you are if there's no public transport can be a huge barrier. Additionally, families don't have to take off as much time from school or from work, and kids don't have to miss as much school. Doing a telehealth visit can be really fast. And then when we have high-risk individuals coming into a place, I think we've talked about this a lot when it comes to vaccinations and how unvaccinated children in our offices put everybody else at risk. So this is the same idea, and it can definitely minimize that. And then it gives us the chance to see kids in their own environment, look at what's happening there for better or for worse, think about some of the safety there. So if you're seeing a family who's on data out in the middle of nowhere and they don't have consistent electricity, and you have a patient who is vent dependent, that's not a great setting to make sure that that vent is going to work consistently. And so that can be an insight that we wouldn't have otherwise. Additionally, families can do these follow-ups a lot more often when they're not doing the check-in and the drive process, et cetera. And then it can give us real-time access to translation services and even allow us to include multiple individuals. So rather than packing 20 people in one room who all care about this child during this COVID situation, we can have multiple people attending a virtual visit if need be. Ways to figure out if telehealth is right for that particular visit, I think, is probably better even than thinking about it patient by patient. In general, if a kid is really sick, you're worried they might be sick. If you might think of sending them to the ER or the hospital, you probably need to see them in person. So anytime you need to touch them, anytime you need to listen to them, get vital signs, and you can't do that in another way. There might be a caveat that if you're going to send the family right onto the ED, you could do potentially a quick telehealth visit, gather a little bit of data, get them on their way to the ED, and then tell the ED providers what you already know, just to help them with that, that incoming patient. But for kids who are mildly or moderately ill, so I think of the perfect case of maybe the patient who just was released from the hospital. And so someone listened to their lungs yesterday, but they need a follow-up, and maybe you don't want to bring them into your office where they're going to be exposed to other viruses and things and might get them sicker. This would be a reasonable telehealth follow-up if they were stable, to talk about what's the, steroid taper, or look at how they're doing. And then if they look bad on camera, you can always tell family you need to come in, or you need to go to the ED as well. So those kinds of things, or kids who are running around the room but have a fever of 101. So those sick toddlers who we know are doing pretty well, and you're just checking hydration or giving family some counseling about the next steps in keeping that fever down or making kids comfortable. Really what I'm talking about is triage as well. And anything where you're not sure what to do, it can be easier to slap on a telehealth and do a 10-minute or a 5-minute, or even have your nurse do a brief telehealth triage and then make a decision from there at times when you're thinking about sick patients. I would just add to, we don't want to replace all well visits with telehealth. And so we do want to make sure kids are coming in at least annually to do those things. Sorry, Amy. And then these are from the AAP, the guidance on necessary use of telehealth during the COVID-19 pandemic. And so even during the pandemic, the kinds of patients AAP recommends come into the office is our initial newborn visit. So someone has to make sure that baby is okay. Anytime we need a comprehensive physical, whether you're sick or you're healthy, office testing, where we're going to do the labs in the office. Now, in fairness, if you're going to write a prescription because they're far away and they're going to take it to a local lab, that probably doesn't count if that's their normal process. Hearing, vision, oral health screening, fluoride varnish. Again, if you're the person who does all of those things, they need to continue happening. And then immunizations. So trying to make sure we're not creating other problems while we're trying to protect people from getting sick by coming in person. And then telehealth should also ideally be used in the medical home if it's possible. So obviously subspecialists can use this, primary can use this, and so on. Absolutely, health equity is something that has to be at the center of these conversations. And I think that a lot of us really were excited about how telehealth was going to improve the equity of how people access care, including more follow-up, more access, less time off. But we are seeing that infrastructure is such a huge issue for families. And so I'll just read this quote: potential disparities in access to telehealth for at-risk and underserved populations should be evaluated and addressed. Adequate functionality of telehealth services depends on access to appropriate communication infrastructure, especially high-speed internet. Pediatricians should be aware of service limitations in many areas and should advocate for enhanced access to services by the extension of this infrastructure to all. Additional needs, such as interpreters and requirements for confidentiality, should also be considered. So in my state, in Indiana, we know that 16% of people do not have access to the internet. So all of those are my families who are going to have a lot of problems with this equity piece. And while there are some tips and tricks we'll talk about, definitely not having home Wi-Fi puts them at a disadvantage. This is a reference slide for people who are just getting into the telehealth billing. We do have some codes for telehealth, and this is how you think about some of those time ranges as well. So there are specific codes now for telehealth, which is great. And then the prolonged services for outpatient that just happened in January. I don't know if folks are already using them for their patients, but they're really exciting. I do want to say that to use the prolonged service code, the 99417, you have to have already hit that level 5. So if you're not already at a level 5, just bump yourself up based on time before you would go to the extra time code. So this is an ideal. We say that because, I mean, we're pediatricians. We work with small children who have a lot of opinions about being in a doctor's office day to day. We already are far from ideal when we have that toddler who's under the table and won't come out, or we're listening to a heart on the floor while we're tickling a kid. We're very good at this. So at minimum, you need a way to converse. So you need a camera, you need a microphone of some sort. So that could be through a phone, a tablet, an iPad, a computer, a laptop. There's a lot of ways to get there, but those are things that you have to have. And then you have to have the virtual platform. If you're not in private practice, your system probably dictates what that platform is. And so that's supplied through your bigger system potentially. And then families may have to download it ahead of time or may have to work on how to use it beforehand. Then internet connectivity. So this just goes better when you have good Wi-Fi. But again, not everyone has good Wi-Fi or Wi-Fi at all. And then the idea is that telehealth platforms should be easy for us and for families to use. And we all know from our EMR lives that the people doing the computer software don't always understand our needs. And so sometimes there's some wrinkles to that. And then we should all be trained, both families and us, on how to use the technology. So that would be the ideal setting. And then the flip side, of course, how do you afford all this technology? How do you have the right technology? A lot of providers and some families, this seems to be changing. Information from early telehealth in the late 90s and early 2000s really talked a lot more about concerns about rapport. And now I think in the digital age of everybody has FaceTimed grandma and grandpa or aunties and uncles or whoever for the last year, I think that this piece has become less of a concern for many families. And even in the literature, we have seen that families have been more confident with this, I think through their own use in a day-to-day setting of technology. There are potential costs for the visit that have been an issue, particularly in the past. And obviously things are going to be changing again now that the pandemic is ending. And so the emergency stuff that has been covering us may be changing. My boss said it really nicely, which is the genie is out of the bottle. We're not going back to the age where there's no telehealth coverage. We just don't know exactly what that will look like right now. And then HIPAA compliance remains a concern for families and for us. How do you keep things private? And then how do families protect their own privacy? And that is a double-edged sword in my mind. Like they absolutely are allowed to have their own private life, but we think about home visitors, so early interventionists are going into the home, and the families we're worrying most about are the families who don't want them in their home. And so that balance as well, are there things at home that we really need to know about from a safety perspective or from a resource perspective? Is this a family who's undocumented, who's afraid that they're going to be deported or other situations like that? And so just knowing that a family might be reluctant to have you in their home this way could trigger another discussion to help suss out what some of those psychosocial needs might be. And then finally, a concern about the quality of the care that you would get on telehealth. And this comes up, I would say not infrequently. And I've had a number of families who have completely declined all virtual services and waited 14 or more months to come in person because of that worry as well. So there are some things that you can do, particularly around privacy. A huge thing to make sure of is that a family you're truly talking to the people you mean to talk to. I have lots of families who take these calls in their place of work and in like shared office space. And so the first thing we have to do is establish, you can give permission to do this, but I am not going to be able to control what other people hear if you're in this space. And I would recommend that we have a private space where we do this. And then likewise, with other adults in the home or things like that. Sometimes for people who are in joint living spaces, actually going down to your car and sitting in your car can be really helpful to give you some privacy as well. So I'm in the Midwest, a lot of people have cars here. Asking who might be able to hear your conversation is also a way of doing that. And then some people have suggested even having people scan the room. That can go back to the privacy piece. People might not want you to see that. Teenagers also, when you're thinking about safety, if you're having a mental health call and you might be discussing suicidality or depression, like if you've done PHQ-9s before, you definitely want to know who else is around and listening. You definitely want to know if they're in a safe space. And then making sure you get a geographic location should you need emergency services. And then the internet connection. Public internet can be really useful. It's not secure and it's not HIPAA compliant. So before we recommend for families who don't have Wi-Fi to use a public setting like at the Panera parking lot or things like that, they just need to be aware that maybe some of this will be less controlled. Preparing for just kind of setting things up for success, if you will. Yes, thanks. Thank you so much, Bethlyn, for putting that in. Yes, PHQ-9 is a depression screener. So it is important to have your team help your family set up. So it's great to have a staff member, but somebody in the office flow to talk about what this is going to look like, how you have to set everything up, and to give them that virtual tour of the software beforehand, whether that's through a link or through an actual step-by-step. So you need in your process to know who's going to do this and how they're going to do it. We also have practices who are able to send out e-screenings. PHQ-9, again, is a great example of a screen that is very easy to send and be filled out through email or through a portal. And then getting information ahead of time, like Vanderbilt's or other kinds of collateral, is really useful as well. This is an example of a tip sheet, and this comes from Healthy Children. I think it's a great one if you're starting to set up this process and don't have one yet. And then at the beginning of the appointment, just as I said, we do want a physical address if you're dealing with a child who could potentially be sick or in distress of any kind, because if we have to send emergency services and the internet shuts down or we lose connectivity, we're going to be in a really bad spot. So get that at the beginning, get the family consent at the beginning, help clarify while you're in this appointment. So this is a little bit tricky. We all obviously ask what parents want to talk about, but I think about hand on the door syndrome. So as in the physical location, we're stepping out like, oh, it's great to see you. Everything's all done. We put our hand on the doorknob and are opening the door. And the family's like, by the way, insert real reason for appointment. So we do have to sometimes address that these appointments shut off really fast. There is no leeway in terms of the hand on the door. What's that last question? And just helping families to understand we want to get at what's important to them and work with them. Engaging family members in the visit. So family members shouldn't be taking a phone call while you're trying to do the telehealth visit. And if it is an emergency, then maybe the appointment needs to be rescheduled. And likewise, especially with younger children or children who are chronically ill, they really need their parent engaged as well. They can't be multitasking in terms of, surfing the internet. They shouldn't be talking to other people. They shouldn't leave the room and leave the child with you by themselves. These are not going to accomplish what they need. And then it's really helpful to have a space for the child next to the parent so that you can see both of them and you can talk to both of them as well. Whenever possible, minimizing background noise. It's not always possible, and sometimes families get really stressed. But if there is 6 dogs and they're all running around the living room, maybe we move from the living room or we put the dogs in another space if possible. So just thinking about some of those things can be helpful. Technical difficulties are really tricky. And there's lots of things that we can all do. So again, that last point is about thinking about access to internet. Data makes this hard and tends to freeze or drop calls. So video really sucks down data. So does their insurance, does your coverage allow you to do a phone call only? And then what can you do with a phone call? That's going to look less than what you could do with a video call. You do want to try and get a good visual on the child and family. And so you might have to help the parent be a little bit like a film director and have them move things or change the lighting. Sitting in front of a window that's open behind them, you're not going to get a good look at anybody. It's just going to be backlit. And likewise, people need to be in a setting where the lights are turned on and distractions are minimized. A lot of times the technology too, you really have to be close to the phone. And I would say that it's not super helpful when families are walking around the house. They really want them to be still for the short visit that you're on because you can disrupt the connection as well. And then having a backup plan, whether that's converting to a phone visit briefly, whether it's we're going to auto bring you in, whatever that looks like, you can have plans for that. So this is just the summary of everything we've kind of been through. Is this a reasonable time to take questions? Okay, so I would love to open it up for questions.